Hello, as you can tell, I'm doing asthma today in my blue shirt, and we are talking about status asthmaticus next. So I am going to share my screen and let us talk about status asthmaticus in just so many words. So that's where we left off, was with patient education for asthma. So status asthmaticus is, in its very nature, a severe asthma attack. That severe it's characterized by severe bronchospasm and mucus plugs. So not only do we have that smooth muscle clamping down and the inflammation of those tissues closing off the airway, we also have mucus plugs, so nothing's getting in and out. Causes asphyxia. So these people are actually like being choked from the inside. Initially, the patient is alkalotic, but they do progress to respiratory acidosis because the CO2 can't be expelled from the lungs, causes respiratory failure. It manifests itself as labored breathing, extremely prolonged exhalation. You'll see engorged neck veins. Those jugulars will get engorged, and wheezing. The wheezing may subside due to lack of airflow, because if you don't have anything coming in or out, there's nothing to make that high-pitched whistling sound. And what will happen is very quickly after you have wheezing or a lack of wheezing, you will have respiratory failure, because if they can't get any air in or out, that completely shuts down the lungs. So this is the bronchiole. I like this image right over here, because this bronchiole is so small and there are multiple forces closing this airway. You can see that there's contracted smooth muscle. There's blood vessels that are infiltrated by immune cells. Excuse me. There's decreased lumen diameter. Lumen is the airway or the opening in the tube. There's inflammation and swelling, and there's excess mucus. So we have this cascade of events that can be really, really damaging for these people. When we're doing management of these people, we want to have them in close monitoring. We're going to be doing objective reevaluation of response to therapies. So we're either using PEFRs, we're using incentive spirometry. We're going to be administering short-acting beta-2 adrenergic agonists. Open up those airways. Systemic corticosteroids to the short-acting beta-2s. We're going to be releasing that smooth muscle. The systemic corticosteroids are going to be decreasing the inflammation reaction. We're going to be administering supplemental oxygen. We're going to be especially alert for central cyanosis and hypoxemia. We may be doing a high flow via a partial or a complete non-rebreather mask, rather than, we're not going to necessarily intubate these people as a first intervention, because if they have no airway, it doesn't matter if we have an artificial tube down there or not. We're going to be giving IV fluids for hydration. Magnesium sulfate will also help induce that smooth muscle relaxation. This particular intervention requires a great deal of monitoring. Usually people who are in a status asthmaticus situation are on the ICU because they need to have that intense monitoring. Mag sulfate can really, if it's in the wrong levels, can really mess with your cardiac. So we want to make sure that we're giving the right amount of mag sulfate to induce that smooth muscle relaxation, but not so much that we cause a heart attack. And these people are hospitalized. Like I said, usually they're hospitalized on the ICU. So death is associated with several risk factors. Status asthmaticus will kill these people. So if they have a history of these severe exacerbations, such as 2 or more hospitalizations for asthma in the past year, or 3 or more ED visits for asthma in the past year, or a hospitalization or an ED visit for asthma within the past month. So this combination of factors can lead to death. I'm sorry, I didn't mean to advance the slide. If they're going through more than 2 canisters of rescue inhaler, short-acting rescue, same one and the same inhalers per month. If they're having difficulty perceiving asthma symptoms or severity of their exacerbations, if they don't have an asthma action plan. We talked about that in asthma chapter 2 about how important it is to be able to have that individualized plan and how to really navigate that successfully, the green, the red, or the green, the yellow, and the red zones. If they have concurrent cardiovascular disease, COPD, or a psychiatric disease, there is a high correlation between a status asthmatic attacks and these particular conditions. Low socioeconomic status or inner city residents, we talked a little bit about that in asthma chapter 1 as well, I believe, because not only can you have you have the cleanest environment you want, but if you're living in multi-unit housing, you can be exposed to everybody else's stuff too. And just because you're a super clean person doesn't mean that your landlord is a super clean person. And sometimes people just need to have shelter or they're homeless, and that low socioeconomic status or inner city residents, they tend to have higher incidences of black mold, not visible, like hiding behind the walls, or roaches or whatever. Illicit drug use is also associated with status asthmaticus as well, because of all of the different problems that it creates within the body system and all of the different shifts that illicit drugs can create within the body. It can trigger a status asthmaticus attack. So for nursing assessment, or a nursing management rather, we're going to be assessing that airway and the patient's response to treatment. We're going to be doing close monitoring for at least 12 to 24 hours. We're going to be assessing for dehydration, blood pressure, and cardiac monitoring. I mentioned that when I was talking about mag sulfate. We're going to want to make sure that the amount of meds that we're giving to be able to create, relax, enhance that airway can really take a toll on the heart. If we're not doing things right, the heart's also going to get really stressed out. So we're going to want them on some sort of cardiac monitoring, whether it be remote telemetry or in the ICU when there can be a bedside monitor. We're working with them on energy conservation. We're removing potential respiratory irritants. For as much as we want, for as much as we appreciate mom sending a huge bouquet of flowers because daughter is in the hospital because of the status asthmaticus attack, we may want to encourage a balloon bouquet instead of a floral bouquet. Tobacco smoke can help, usually when they're hospitalized. I hope we don't have people smoking in the hospital. There's rules against it. Doesn't mean that it happens. Perfumes can set people off. So, and cleaning agent odors. That's why when we're having you go to clinicals, we're having you reduce your perfume usage. We're having you reduce your dryer. We may have you reduce your dryer softener smells, your laundry smells from your clothing because they're potential respiratory irritants. And then we're also going to be reviewing their current medication plan and helping them determine if it's appropriate, if it's not, making recommendations to providers about potential changes so that these people can be more successful and not have to be here, right? That's the goal for all hospital acute care nurses is I hope to never see them again. And so if we can get them on the current, on a better plan, hopefully we never see them again. So for all 3 chapters for asthma, these are the references that I used to be able to put together this slideshow. I'm going to stop sharing my screen. And this concludes status asthma and status asthmaticus. So there's a total of 3 chapters. And please come to class with questions. Please email me questions. Please reach out and feel free to come with me with questions. If it's the middle of the night, this is all in Lewis as well. So I hope that you have a wonderful day and we will see you later.